Welcome back to Pulm PEEPs, everyone. We're back and excited today to be bringing you another Pulm PEEPs Pearls. Today, we're going to be talking about something that comes up all the time on your MICU rounds. That's steroids and septic shock. When do you give them? What do you give? And why does it even make sense to do so? So, to set the stage for today, we have a patient in our medical intensive care unit for management of septic shock from a urinary source. You have the fluids going, antibiotics are going, and you think that source control is achieved. But the patient's still on norepinephrine at zero point 0.3 mics per kg per minute, and you don't really anticipate any signs of tapering this off in the immediate future. So on rounds, you have a great team member that asks, should we add steroids? So before we get into the evidence, why would steroids help in a bacterial infection that seems, for some could be a little bit counterintuitive?
100%. I love this topic. It's a great question. It comes up all the time. And it's something we talk about all the time because there's always evolving evidence, which we'll get to. I think when we think about sepsis now, when we think a lot of conditions in the ICU, we're often now thinking about the phenotype of what the patient has. And so, in this sense, we know that a lot of patients who have sepsis have an inflammatory immune response that is really overwhelming the HPA axis. Cortisol production is not keeping up with physiologic demand, and things are going awry from really the patient's response to the bacterial infection as opposed to the bacterial infection itself. We have to focus on both, but oftentimes that inflammatory septic shock response can have and cause damage that's even beyond just what the infection is doing. And so this portion is really not about treating the bacteria. The steroids are not adding bactericidal or bacteriostatic effects to the antimicrobials, which is why antimicrobials are number one. You always make sure they're in right away. But the idea behind this is that we're treating critical illness related corticosteroid insufficiency that may help the body keep up with the inflammatory response that is happening to this infection. Hydrocortisone really helps in two main ways. That's what we're talking about adding mostly. We'll talk a little bit about mineralocorticoids and fludrocortisone. But first, it blunts some of that dysregulated inflammatory response. And so we see, you have patients who are ultra febrile, who are really vasodilated, who are really trying to do everything they can to fight this infection and get immune cells to the right places, but that can cause problems for them, such as being so vasodilated that you have hypotension, such as the damages that happen when you have an extreme febrile response. Second to this, hydrocortisone itself restores some vascular sensitivity to catecholamines. So we know that in septic shock, adrenergic receptors get downregulated. We know that you get a vasodilatory response, and steroids themselves help turn that responsiveness back on. So clinically, the first thing you really notice is that you get weaning of vasopressors or a bending of the curve of adding new vasopressors or escalating your vasopressors, and less so do you get an improvement in fever curve or white count right away. It's important to recognize, as I said before, that there's been a lot of work on sepsis phenotypes. And so basically, I'll just preface that all the studies we're talking about right now have not really taken into account new phenotyping literature about hyperinflammatory or hypoinflammatory septic responses. And so really, we're just talking about steroids to address inflammatory response in all comers with sepsis. We haven't, none of these trials are sort of distinguishing based on some of the things that we know about in recent years.
Thanks, Furf. And such a good reset to remind us why we're doing steroids in the first place, right? For those listening today and those caring for critically ill patients, but if the patient's asking or if families are asking, why are steroids helping, as you mentioned, Furf, not for infection control, but really to reset this HPA axis. So I think really a good frame for our further discussions. So, Furf, I know there's been a lot of trials on this specific topic. There's been a lot of back and forth, but I'm curious, for those listening today, what does the evidence actually say? And for those caring in our ICU today, what studies should we know and refer back to?
Yeah, 100%. I think inevitably, if you are in internal medicine, and definitely if you're in a critical care fellowship, you will at some point do a journal club on these 4 trials. So there are many more than these 4, but there are 4 main trials that get referenced and discussed in the discussion, plus multiple systematic reviews and meta-analysis. Okay, so here's the saga. So the early initial signal, or an early main trial that we're quoting, is the Annane trial in 2002. Smaller French randomized trial. This showed a mortality benefit in patients when they were getting hydrocortisone, and they actually got fludrocortisone as well. This was in this trial, they really looked at what the cortisol response is. And so they were doing ACTH stim test. They were doing cortisol stim tests and testing ACTH. And for people who were non-responders, there seemed to be a mortality benefit to giving supplemental steroids in these septic patients. The methodology here was a little criticized. The findings weren't really replicated very cleanly in some other studies. For example, some of the non-responders that we say to ACTH may have had absolute adrenal insufficiency, so like really, really low baseline cortisols. Maybe they were on steroids at home, and not just like non-responders in like what we think of as the typical sense in sepsis. But suffice it to say that cortisol response testing was a little bit messy. And so even though there was a mortality benefit, this trial was a little bit messy. That being said, it was enough to get people to say, maybe we should be using this in sepsis. So this is followed up in 2008 with the Corticus trial. This is trying to answer these questions that are lingering after the Annane trial. So this is in 2008, and this is using hydrocortisone alone. This really showed a faster shock reversal in the patients who got supplemental glucocorticoids, but no mortality benefit. And this was even in patients who were steroid non-responders. And so this was a little in contrast to the initial Annane trial. Again, still like a trend that there was some benefit in the sepsis, but no mortality, and that's what we most care about for this. It also raised some concerns about superinfection in that trial. These concerns have generally been allayed in future trials, and we'll talk about safety in a little bit. But this was the first where we were worried that being on steroids, suppressing the inflammatory response, could lead to more superinfections. As I said, the lack of response was stratified by responsiveness or cortisol responsiveness, ACTH, non-responders or not. And that's an important milestone to remember in this conversation, because the fact that this trial didn't show any response really is the cornerstone of why we don't do this anymore in sepsis patients. We really don't test cortisol and cort stims before we decide on steroids anymore in the modern ICU. Okay. 2 studies, then there was a break for about 10 years, and there are 2 studies that come out that then we're continuing this conversation. And these are adrenal and or approaches, depending on which person you're talking to. So adrenal enrolled about 3,800 patients. It used hydrocortisone alone. It showed faster vasopressor weaning, just like Corticus, but again, no 90-day mortality benefit. I call it approaches. Some people call it APROX. Used hydrocortisone and fludrocortisone. That's similar to the Annane trial. And this did show a mortality benefit at 90 days. And so this was, again, lending towards the in favor of steroids trial. The most consistent signal across these trials is that we get faster shock reversal, lower use of vasopressors, shock and organ failure gets better quicker. Whether that translates into a mortality benefit still kind of is up for debate based on these conflicting results.
Awesome, for really highlighting 4 kind of landmark studies that we should be aware of today. Some of you may know these forward and backwards, but if not, you can always go back to these and read the full article. But Furf, I think you did a really nice job of highlighting it as we continue with our Pulm PEEPs Pearls for today. We talked about why steroids, we talked about evidence behind it, but now I just want to focus a little bit more. So like, who's actually getting steroids and when? So Furf, when do you say to your team, let's go ahead and pull the trigger and start Hydrocort?
Yeah. So again, the summary from those 4 is we're probably getting shock better faster. We're probably getting off pressors faster. Question about mortality, overall pretty safe. And so this continues to be a lingering question. The 2021 Surviving Sepsis Guidelines suggested to consider steroids when a patient was on levo or epi, and they put a level of 0.25 micrograms per kg per minute or higher for at least 4 hours, despite adequate resuscitation. So again, you always have to make sure this patient got appropriate, adequate fluid resuscitation. as you all know, early in 2026, there was an update in the surviving sepsis guidelines. It moved away from a specific trigger. Really said that if you're a septic patient, it doesn't seem like you're responding well to vasopressors or you have escalating requirements. That's when you should consider this. But again, quality of evidence from moderate to low. And I think this is reflective of the overall conversation. So if you want to look back at that 2021, I think the 0.25 is a reasonable bedside trigger. There are situations when you should go a lot faster than that. Again, if a patient is known to be adrenally insufficient or at risk for that, they're on home steroids, you're going to use more glucocorticoids, you're going to use them quicker. A patient who is in, florid free pressure shock right away, you're probably going to pull the trigger right away as they're coming in the door and you're doing your resuscitation. I'll say that, there are other things to consider as the patient is escalating in pressure. So for me, my first question, if I know it's sepsis, let's just say we know it's sepsis, they're on escalating Levophed. My first question is, should we add vasopressin, right? According to the VAST trial, and we can dive into that in another episode, but I pull the trigger on that first. And then if I still have escalating pressure requirements, then I am usually throwing steroids on as well, because I feel like I'm losing control of the septic situation. So for me, it's escalating Levophed, then I'm adding vasopressin, and then after that, I'm considering adding steroids. One practical point, just to really hammer home, and I mentioned this before, is that you should not be waiting for the ACTH stimulation test. It does not reliably tell you who's going to respond. It really just delays treatment. The data is extremely mixed on this. Sepsis is an elevated cortisol state, but it can also dissociate ACTH and cortisol. There's depletion of cortisol binding globulin. This test is extremely messy. And so I think everyone is in agreement that you should make a clinical decision about using glucocorticoids, but you shouldn't be waiting on a stim test.
Yeah, such an important point to remember, and I think so practical as well. Okay, Furf, you told us who we're going to give steroids in and why, but what do we actually give, right? So if you're on the team and someone is recommending the dose and someone's putting in orders, what's the regimen you do? What is a steroid, and what's the dose? You mentioned, I know you alluded to some of this, but I know there may be some institutional variation, but would love to hear you comment on that.
Yeah, 100%. So the pretty much universal dose that's used now is hydrocortisone, 200 milligrams daily. One thing that's still tough is that a bunch of these trials were given as hydrocortisone continuous infusions. Again, as we said, 2 of them are in French trials. I've never worked at a hospital that does continuous hydrocort infusions. It's not something that we see as commonly in the United States. And so this usually gets broken out to 500 Q6, and so that, or 50 Q6, I apologize. So you get 200 milligrams per day. Like we said, if you are on some adrenal insufficiency at home, you're on baseline steroids, we usually kick this up to 300 milligrams a day. You might do 100 Q8. A lot of people start with a dose of 100 milligrams of hydrocort just to sort of like gain control of the situation, hand wavy. But 50 Q6, 200 a day is pretty standard. One thing that is worth discussing is the addition of fludrocortisone. So this is still an unsettled question. The 2 trials that have shown mortality benefit have used fludrocortisone in addition. And so if you are a trial purist, you're an alien come down to earth to practice medicine and you're reading trials, I think it's reasonable to look at fludrocortisone and say, hey, we should add this. These trials showed mortality benefit. In reality, hydrocortisone has mineralocorticoid activity. There's been a couple systematic reviews and studies to try to see if fludrocort has a benefit, and they generally lean towards them not having a benefit. A lot of people don't add the fludrocortisone in addition to this. I think that's not a mistake too. I think it's a pretty safe medication. But even though those 2 trials used it in addition, many people forego that in the sepsis literature. And we really think the hydrocort is having the main benefit. A meta-analysis in 2026 tried to, again, answer this question of the fludrocort. It showed a mortality benefit versus hydrocortisone and fludrocortisone versus placebo, but not of hydrocortisone plus fludrocortisone versus hydrocort alone. And so, again, that sort of is in the prevailing wisdom practice that often this is not given. If you do decide to give it, it's just an oral med. It's 50 micrograms, or you give orally or via an NG tube or OG tube, so it's pretty easy. But it's another question that remains to be answered.
Perfect. I feel like we'll have to do some informal poll. I feel like I'm not one that tends to add fludrocortisone to hydrocort in these scenarios, but I think if you're a team member and you recommend fludrocortisone, um, you know, I won't judge. I think as long as there's some honest about the uncertainty of adding the medication, but I don't know. I don't know. Are you a judge or Furf if someone wants to add it?
I now have tried in recent years to be really reflective on all my decisions. I trained in places where fludrocortisone wasn't used, so I generally didn't use it. That being said, the best trials for using hydrocort are ones that use fludrocortisone as well. And so I think my practice still falls towards generally not using it because that's how I think the meta-analyses break out. But I don't think it's wrong by any means. And again, I do think it's safe.
Awesome, Perf. And I think one of my kind of favorite questions from the team when we're rounding is, once you start steroids, how long are you going to use them for? Are you going to taper? Kind of what's the plan?
Yeah, this is like the most voodoo ridden thing in the ICU because like ICU is messy. People's courses like go up and down. And so I've seen a million people who are like on 50 Q6 and then someone wants to taper. We go to 25 Q6. The patient does a little worse. We go back up to 50, and nobody, it's very voodoo ridden. Most of these trials had some varying approaches. Adrenal approaches were 7 days. There's a Vanish trial, which we didn't talk about as much, that has a taper at the end after 6 days. Some people say to keep it on until the levofed comes off. I've seen people leave it on until the pressors come off, which can be a really long time, especially if people get into that sort of vasoplegia, loss of vascular tone phase of the critical illness. Overall, I would say 7 days seems to be the most commonly used in the ICU. And I think the one thing that's really clear is you do not need to taper. You do not need to taper for adrenal insufficiency. And I think if you're stopping it, you just stop it. If someone totally goes off a cliff and their pressures quadruple after you stop it, fine, you can add it back on. But most people, they've gotten the benefit they're going to get by that 7 days, and you should just come off and start simplifying their regimen.
Yeah, totally true. Just recently had a patient who we had started stress dose steroids on, and the next day she was off pressors. We thought we got good antimicrobial regimen, but she was like, "The steroid is making me talk nonstop. Can we please taper?" And I was like, "This is a perfect reason to go ahead and just stop it, stop it completely. There's no need to taper." But for some great things about steroids and potentially resetting your access, helping with outcomes. But right, every medication has strengths, every medication has benefits. What are some pitfalls that you and the team tend to discuss when you're starting stress dose steroids for your patients?
So let's start with the one that's like clearly happens and is one that has to be addressed. So that's hyperglycemia. People who are on steroids are going to have hyperglycemia. We know in the ICU that glucose control is beneficial for overall survival. And so you have to control this. You just need to be monitoring. You're in the ICU. You can use an insulin drip if you need to, right? Like you just need to be doing very close monitoring of this. And we know it's going to happen, right? So you definitely have to be on top of it. That being said, not a signal for like major DKA episodes, like major hyperglycemia complications in any of these trials, just that you do have worse glycemic control. Then I'm going to go to the one that I think is the most concern that gets quoted the most, and this is superinfection or fungal infection gets raised a lot. I'm sure in individual patients, there are times when giving steroids has led to worsening infection, especially if there's a undetected fungal infection or something like that. That being said, in the overall literature of this, that signal is not strong enough to be convincing, right? And so generally we see that in sepsis, steroids are helpful and do not lead to higher rates of superinfection. Superinfection happens in the ICU. And so I think we should be regimented about weaning, like we just talked about. I mean, we are coming off steroids, like we just talked about. But this is not something that has gotten to a point where there's some statistical significant increase in superinfections or severe infections for the patients on steroids. So we can feel pretty comfortable with that. Other side effects to consider: muscle weakness, obviously critical illness myopathy. We've done an episode on that. Being on steroids worsens that. A short 7-day course like this in the throes of acute illness likely isn't having a huge effect, but something to be aware of. GI bleeding, just follow general PPI prophylaxis recommendations, which are always evolving, which should probably be another episode. And then alterations in sodium control, hypernatremia, just things to watch for. Important to note, though, again, overall from this literature, we would say, I say two things that I think we know about steroids and sepsis: shorter duration of vasopressor support and relatively safe in sepsis. Those two things we know. Whether it helps mortality, whether there are certain patients that benefit more than others, still questions that we have to answer. And so I think that we can feel comfortable from a safety standpoint using them.
Awesome, Furf. Always so great to get to hear from you and all your wisdom and pearls. Again, with these Pulm PEEP pearls, we're really trying to keep these episodes 15 minutes or less. And our time together today, for would love if you could just run down your 5 Pulm PEEP pearls for the day.
Absolutely. So pearl number 1, steroids and septic shock restore catecholamine vascular sensitivity and blunt dysregulated inflammation. The clinical target is vasopressor weaning, not infection treatment. Pearl 2, faster shock reversal is the most consistent finding across these trials that we have discussed. Mortality benefit is seen in 2 of these trials, is not seen in others, and so is still an area of controversy. There are likely some patients who do have mortality benefit, but we have to identify who those patients are. More work to come. Pearl number 3, per the surviving sepsis guidelines, a practical threshold from 2021 is levo or epi at a rate of 0.25 mics per kg per minute for 4 or more hours. Newer recommendations do not have that strict guideline, though. So to be up to date of evidence, you need to be making a clinical decision. Pearl number 4, the general dose is hydrocortisone 200 milligrams per day, and you can give it in whatever form you'd like, 50 Q6, continuous. Adding fludrocortisone, as we talked about, mirrors 2 of those trials, but meta-analyses don't find a benefit of it versus hydrocortisone. And pearl number 5, steroids appear to be safe in sepsis. You have to monitor and treat hyperglycemia, but there does not seem to be a marked increase in rate in superinfection. Thank you guys all for tuning in. We appreciate you coming to this Pulm PEEPs Pearls episode. Credit to George Doumat, a resident at UT Southwestern, who helps us with these episodes with the background research. Really appreciate it. And we hope you guys will tune in next time.